Okay, so you can see that Sebastian and I wear the special costume for crazy people to put in 2 implants in one knee. Okay, but we think it's a good idea, and there are some very important tips. 5 of which are technical, which means you have to be a very able surgeon and you have to understand what to do. Let's look at the indications for bicompartmental, okay? And I take it as this is the patient that you would love to do a uni on, but unfortunately they have significant patellofemoral OA. It's significant and symptomatic patellofemoral OA. And the way you detect those in your indications is they have the pain on squatting and kneeling. They often have swelling, and they have a patellofemoral grinding test. And so a good test is the 1-finger pointing sign, which means that if they identify that, they adjust the uni. It doesn't really matter what the X-ray of the patella looks like because it's asymptomatic. If they're using their whole hand to say the pain is all over my knee, particularly at the front of the knee, and they have patellofemoral osteoarthritis, then you begin to think of bicompartmental knee. The investigations are very simple. I tend to use X-rays only. You want to see bone-on-bone contact. This is the same indications as you would use for a total knee. And of course, you can produce a perfect solution with a bicompartmental implant that allows you to address both the patellofemoral disease and the medial compartmental disease. So we hear about progression in a lot of these talks, the progression from a uni to patellofemoral, or progression of patellofemoral to medial disease. And that's the same whether it's a mobile or fixed design. It's about 30% in both. But for me, this is not a stepping stone into a total knee. Why should you do a total knee? Here the patient has had a uni in 2007, so the other indication for bicompartmental is progression. So you still keep the cruciates, you still keep a functional knee, even 12 years later. So, and that happens for mobile bearings as well. You see this progression later on. You can deal with it with a bicompartmental knee. So medial and lateral femoral positions we can take together. The lateral is different to the medial, so we're talking bicompartmental. That can be lateral and pat-fem or medial and pat-fem. You can see this clearly, how different it is for the implants. That's white side line. And you can see on the medial side, I'd like to tilt it in a little bit to follow the kinematics. But on the lateral side, it will be perfectly perpendicular. On the medial side, I will make it more to the midline to address the kinematics, but on the lateral side, I will put it as far lateral as I can to address the kinematics of the joint. And you can see why that is. This is a view from above, and you can see that on the medial side, I want to externally rotate the tibia. On the lateral side, I want to internally rotate the tibia because of the kinematics. On the lateral side, from flexion to extension, we will see the kinematics bring the contact point inwards. And that will be just behind the patellar tendon. Now, on the medial side, of course, we will put the implant towards the center. If we put it on the lateral side, like for a lateral, you'd see as we went from flexion to extension, we would end up with edge loading. And so that isn't desirable, so we would medialize or put it near the central midline. On the lateral side, of course, we do completely the opposite. If we put it near the midline on a lateral, we'd end up with coming off the polyethylene. So we would actually lateralize the lateral side as much as possible, so we kept it on the polyethylene. So you see the two sides are completely different. If we added a pat-fem at a later date for progression, what we'd want to do, what I like to do, is the patella resection first. I check the patella runs in the native groove, and then I actually do the uni, because that changes the alignment, the varus valgus alignment of the knee, which alters the patellofemoral tracking, which alters the trochlear position. So you just heard what Seb said about putting the tracks underneath the train. Whoever thought about that was very clever. Okay, and so we've changed our positioning of the trochlear, and you heard Seb talk about that, because before we talked about a metal trochleoplasty, and even some people in this meeting have talked about that. And they say, okay, there's a hypoplasia, so we have to correct that to make our X-ray look better, and so they talk about capturing the patella. Okay, and so they would say, I put my implant in like this because it looks better on the skyline view, and that's how I do a total. And what that means is that your skyline view looks better, but actually you stress the lateral side. So one of the commonest indications for revision of patellofemoral side is pain and clunking. That's because we've tried to push the patella or capture it in an unnatural way. And you can see why that is, because in this perfect skyline view, you can see that there's soft tissue pain. So the soft tissue sensitive concept is orientating, as Seb said, along the lines of the existing trochlea, because then all the tensions in the soft tissue are the same, the patella tracks in the same way, and we don't have the issues of tightness and pain in the soft tissue. And so sometimes that gives you some weird post-operative x-rays, and you might think this is malaligned, but if you look at this true lateral, we can see that the patella and the trochlea are perfectly matched. So, orientate to the patella track, not the classical orientation of the total knee. This is not a total knee. And then finally, the patella resection. We've talked about how we measure the patella resection to make sure the polyethylene is correct, but actually we never really look at the trochlear resection and how much we take away. And the whole idea would be to balance this joint. Okay, so we've talked about how sometimes you take away 10 millimeters of bone and replace it by 6 millimeters of metal, so that's an understuffing of 4 millimeters. And we certainly wouldn't accept that in balancing the flex and extension joint. It's a significant difference, because if you look at the forces, if we overstuff the joint, you actually increase the quads travel and you increase quads pressure by almost twice. If you understuff it, then what you induce is laxity, and the tissues have to work twice as hard to achieve the same amount of work. So you can understand why it's a demanding joint. And then finally, a cement technique, and we've heard about that just now. It's really, really important. And I always put the cement on the metal first and make sure we have a proper technique, just as we would carefully cement a total knee. Aseptic loosening is a common cause of failure. And so, in summary of these 6 points, the indications we've talked about, be aware that the two unis are completely different in their orientation. Be aware of the trochlear position. This is not a total knee. And you balance the third space and make sure you cement it correctly. Thank you very much.